So we'll now move on to our final talk today, which is going to be delivered remotely by Veronica Cabreira, but I think she will be available for questions afterwards.
Good morning, everyone. I would like to thank VNPA, first of all, for the opportunity to present this work here today, and apologize once again for not being able to attend in person due to professional commitments. So I'm going to talk about functional cognitive disorder. And as you know, this is one of the most common causes of non-neurodegenerative memory complaints. And in some series, it makes up to a quarter of the patients attending the memory clinic. But the diagnosis is not straightforward, and sometimes it can be challenging because there is a striking overlap with symptoms of neurodegenerative dementias. And even though the diagnostic definition was proposed in 2020, so like almost 3 years ago, we do not have still a clear-cut diagnostic test or clinical profile that helps us to identify these patients. And back in 2009, Schmidt et al., they developed a scale to identify FCD as a 10-item questionnaire. So they were asking questions about working memory, concentration, and this scale obtained a specificity that was very high, close to 100%. So it was very specific to identify FCD, but unfortunately, it failed to distinguish FCD from healthy controls. And since then, since 2009, our knowledge about FCD increased exponentially. And as I said, the diagnostic criteria was just published in 2020. So we need new scales that are able to incorporate all this current knowledge that we have. With this study, we aim to develop a bedside screening tool that will help us differentiate between FCD and neurodegenerative causes of memory complaint. And as a secondary aim, we also sought to explore if the diagnosis is concordant across different countries and treatment settings. And this is the first time this is being undertaken since the publication of the diagnostic criteria. The way we conceptualized this study was as a multi-step Dolphin methodology, and for this we invited a panel of experts with an interest and experience in cognitive disorders. To first design and inform our survey, we conducted a literature review to identify the main clinical characteristics, language, and behavioral profiles, which are the most promising diagnostic biomarkers that we have today. And this literature review will hopefully be published in the next couple of months. Then the participants had to complete anonymously several questionnaires over 3 rounds, as we will see in the next slide, and they were fed back their response and the group's response after each round, and they were able to change their answers if they wish to in the next round. So the first and the second rounds of our questionnaire included clinical vignettes, so with fictional clinical scenarios that the experts had to first propose a diagnosis and then also say how they would approach these patients regarding the investigations, treatment, and follow-up. And the last part of the questionnaire also included a list of statements that were diagnostic clinical signs or characteristics that they had to appraise in terms of how much these characteristics will favor a diagnosis of FCD using a 7-point Likert scale. And then, so qualitative, thematic analysis and quantitative analysis were undertaken, not only to see how they appraise the clinical vignettes, but also to achieve consensus to build our diagnostic checklist. So this is just a summary of what I was just describing. So first we conducted the systematic review, and then in the Delphi round 1 that was concluded in May 2022, 45 participants replied to the questionnaire, and then we, after analyzing and incorporating any suggestions, we conducted round 2 around August 2022. 39 participants completed this second round, and they were sharing any thoughts, any missed items that were incorporated as well. And then we arrived to the prototype. We achieved the prototype of the diagnostic checklist. We had a few doubts in some of the items that had achieved lower consensus. So you're asking the participants to appraise this diagnostic checklist and provide their last feedback before the validation that we are now aiming to start. We are just going through the painful procedures with the ethics, but necessary, of course. And here in this table, you see how we classify the consensus. So basically, we were calculating the percentage of scores that were obtained for the bottom items of the bottom ratings of the Likert scale. So any items that had obtained more than 50% of the participants, classifying them as important or extremely important, were categorized as consensus, and then this varied if it was low consensus, moderate, or strong, according to the percentage obtained for these scores. So this is just a summary of the whole study. So study 1, systematic review, as I said. Study 2, then the Delphi multi-step study. And then we were refining the checklist that we obtained with our results. And now we are here in the next step that we aim to validate the checklist retrospectively in a well-characterized cohort of FCD and controls, memory complaints due to other causes. And with these, we'll be able to explore the discriminative power of our scale in a real setting and establish the optimum cutoff points. And then we aim to finally also publish some recommendations on how better to identify FCD, taking all these into account. So 45 experts participated in our study. They had a median of 13 years of experience dealing with cognitive disorders, and they were from 12 different countries. The vast majority were neurologists. They stated that they had seen, the majority, 47%, had seen between 10 and 50 patients with FCD over the last year. The majority of these patients had between 30 and 65 years old, and 69% of our participants said that FCD patients comprise between 5 to 30% of the patients attending their memory clinics. And this is just a brief overview of the clinical vignettes analysis. So I'll just highlight 2 points. So we can see in this figure, first of all, that the participants, for the first time we are able to prove this, but this is very reassuring because we see that the participants are clearly able to distinguish what is a neurodegenerative disorder and FCD. So we see here Alzheimer's disease in the first column, and then PPA here in the second last. And we see that they were clearly able to identify and label this in an homogeneous way. But when we look at in the second and third columns, and also the fifth, we see that FCD was really heterogeneous in the way the participants, the experts, were labeling, and probably this results because of differences in how people frame this cognitive disorder. So some would, for example, consider this as a part of a mood disorder or call it subjective cognitive impairment. And here on the right in this table, we also see that we were measuring the strength of agreement regarding investigations and treatments. And we see that even though for all this is a complicated subject, so we see that for all of the clinical scenarios, there was a fair to moderate agreement, but the agreement was still lower for FCD versus the other conditions. And this is the prototype of the diagnostic instrument that we found. We call it Find FCD, so diagnostic instrument for FCD. And the part A on the left are the core criteria. So these were the statements that obtained a higher consensus, so strong level of consensus. So the demonstration of a discrepancy between the level of symptoms reported and the objective functioning, the patients being able to detail several examples of their memory complaints, or a variability according to different situations, or the symptoms fluctuating in different situations. Any of these criteria make up 2 points of the scale. So if the patients fulfill this will correspond to 2 points each. And then criteria that obtained lower consensus, so moderate in yellow and low consensus in green, these correspond to 1 point each. And for example, we can see here that the ability to recall previous interactions with other doctors, having a non-cognitive functional neurological disorder or somatic symptom, obtained moderate consensus, And then other items that were more debatable. This raised more discussion among the participants, were the patients being more aware of their cognitive changes, sometimes self-referred, having a normal or an incongruent cognitive performance, symptoms being stable or improving over time, the patient being able to date the symptom onset with precision, the presence of a psychological stressor, or the ability to answer compound questions. And all these items will be appraised and analyzed carefully during the validation process. So if they prove to be non-discriminative or redundant, they will be eliminated from the final version of our checklist. So to conclude, this checklist comprises 11 items then. This was developed based on a key set of clinical domains with expert opinion and literature review. This is supposed to be a brief, easy to apply, simple and objective scale to be complementary to a more comprehensive clinical assessment. And the overall goal, as I said, is to increase the diagnostic accuracy with the purpose of helping direct patients to early post-diagnostic treatment. We will establish the optimum cutoffs and discriminative power in our next validation study. And obviously, the better we identify these patients, the better we are able to treat them in clinical grounds, but also this will make it easier to recruit them for future research studies, not only for FCD, but also, for example, for Alzheimer's disease trials. And yes, so this is just to conclude, this study is part of a wider project that I'm doing that aims to improve diagnosis and treatment of FCD. I'd like to conclude just by thanking my amazing team of supervisors, Professor Alan Carson and John Stone, also Laura McWhorter and Lisbeth Frostholm for all their valuable inputs, and all the amazing team of collaborators as well. Without them, of course, this wouldn't have been possible. Thank you.
Thank you, Veronica, for a fantastic presentation. I'm sure we have some questions from the audience. Gentleman here.
Hi, thank you so much for that talk. I wanted to ask specifically how, if you could comment on the possibility of differentiating FCD from something like potentially like inattentive ADHD that doesn't get picked up on, or that is sort of subclinical but then emerges later on. Because I noticed that some of the criteria that seem to have the strongest consensus seem to be about inattention and fluctuation, which is also quite common with ADHD. And there's also quite a lot of work about the sort of effect of ADHD on things like self-esteem and so forth, which seem to also kind of play roles in functional disorders where your belief about your ability is quite important.
So we didn't account for ADHD in this scale. It's a very good point. Actually, we know that sometimes they are associated, so functional disorders in general, but particularly functional cognitive symptoms might be associated with ADHD, might be something that we consider in the next phase. But you are absolutely right. And the reason why we consider or the experts consider overall the variability over time as a strong factor, and we attain 2 points to this factor, is because we know from the pathophysiology that patients seem to be particularly impaired in specific times, for example, in the workplace or work setting, rather than when they are relaxed, or for example, when they are being evaluated in the clinic, when we are performing our cognitive assessments, when they feel under pressure, they tend to perform poorly only in those situations. And particularly when the task that we are evaluating is under the focus of attention at the time. So yeah, these are issues that are still being described. Even this morning, I was just talking with colleagues also about the issue of self-diagnosis in adults, so self-diagnosis of ADHD in adults, which is becoming an issue in our clinics as well. So I completely agree that probably there is an overlap here between the two situations, and we might need to account for that when we design a tool like this.
Great. Any more questions from the audience? Right at the back there, at the top.
Hi, can you hear me? Hello. Thanks for a lovely talk. I'm just concerned that our toolbox will be very, very overflowing with tools. We've had quite a few tools today, and I can see the research utility, definitely, but in a busy clinic, you know, should we really run through multiple tools, if you see what I mean, rather than taking history, thinking, oh, yeah, they're not answering my questions quite directly, they've got some fits, they're not remembering things, you know, what is this? Because I just rue the day when we have to run through 20 tools. Thanks.
Mm-hmm. Mm-hmm. Thank you for the question. It's a very good question, but the way we, for example, we plan to validate this scale is on a retrospective way. So, and for example, from the analysis of the clinical vignettes that I showed in one slide, we can see that having a knowledge for these positive features is extremely useful, because if we can disseminate this kind of tools, and if we can build this knowledge, the clinicians will be more aware, even if they encounter these characteristics during the normal clinical history. So if we are already almost, let's say, formatted to identify these characteristics, maybe when it comes the time to apply the scale, we already inquired a few of the points that we will be evaluating with our scale. And as well, I think that I agree we have a limited time, but if this becomes disseminated, I think it's relatively possible to apply this retrospectively. So after the clinic, for example, when we are doing our letters, or in a short period of time. So obviously we did not test yet how long it will take to apply the scale. I think it will be relatively brief though. I can say that in the end of the third round, we had a scale with 8 items, which I think would be ideal, maybe rather than 11. But then we decided to go broad in this stage of the validation. And in my personal opinion is probably after the validation, we will have some items that are very much well correlated between each other, and probably the ones that obtain a lower consensus. And if they prove to be redundant and they do not really discriminate between the two populations, we might end up deleting them. So maybe we'll end up with a scale with 8 to 10 items, I would say maximum. So
I'm going to take, because I can see there's a lot of interest, 2 more very quick questions, one on the back, and then I think that's Dr. Price over there. So, yeah, very quick, please.
Okay, thank you. Right at the start, you referenced another scale that was very specific for picking up FCD, but didn't distinguish from healthy controls. And I was just wondering why it really mattered in a clinical setting, because the healthy controls wouldn't have symptoms, wouldn't be coming to see us unless, by definition, they kind of did have functional symptoms. So I just thought that was probably still a useful scale to use. More a comment, I suppose.
Yes, this is a study that so the original study was the scale was designed to distinguish between the two populations, and in fact it was very specific. But we know that we can sometimes have people with so memory lapse and memory complaints is a normal human experience, and probably FCD is on a continuum between what is a normal memory lapse and what is a neurodegenerative condition. And we know that then we have several degrees of impairment and a lot of variability here, which I think the study was done in 2021, if I'm not wrong, by Laura McQuarter, and it showed that in people with just normal memory lapses, so people who were not concerned about their memories, in fact, so they did not have FCD, but they were still being identified by the scale as probably having FCD. So maybe the scale was too sensitive, and we will be capturing a lot of people who actually don't need medical attention. We also need to bear in mind that we do not want to overdiagnose these patients, and we need to be very specific about the ones we are going to refer to treatment. So in some patients, I believe we might be able to just to say that this is a normal memory experience is not a functional cognitive disorder without needing to apply this scale. I don't know if I answered the question, so I'll need a little bit.
Thank you, Veronica. Last question.
Thanks for the talk. That's very good. You mentioned treatment. It's a bit of a cruel question from me. Any thoughts on how you treat functional cognitive disorders?
Yeah, thank you for the question. So that is the $1 million question. So my PhD actually is on treatment for functional cognitive disorder because the short answer is at the moment we do not have a specific treatment for functional cognitive disorder. Obviously, this is a multi-step approach as for many other functional neurological disorders. So at the moment, what we do is first frame the memory lapses, as I was just saying. So for the patients to understand what is a normal human experience, what is that is normal for everyone to have memory lapses, and also we try to identify comorbidities that might be targetable. We also explain how the memory works and the attention circuits, and we try to identify other factors. For example, usually these patients tend to catastrophize. They tend to be very perfectionist about these thoughts, so any obsessive thoughts as well. So it's more around this at the moment. What I'm trying to plan, I can't really reveal much at the moment, but there is some preliminary data. We know, for example, that group therapies didn't work well in these patients, but there is some preliminary data in acceptance and commitment therapy, for example. Some adaptations with CBT, psychoeducation more directed to the memory processes. So yeah, but it's what I'm now developing, and the idea is to have like an intervention that will be self-helped, and so that the patients can apply remotely, maybe with some minimal support from a therapist or a doctor from time to time.
Great. Thank you very much, Veronica.